Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features expert answers to clinician questions on testing for biomarkers relevant to immuno-oncology and using the test results to optimize treatment decisions for various solid tumors. This episode is part of a larger educational program entitled Application of Existing and Emerging Biomarkers for Immuno-Oncology Across Tumor Types. During this podcast, Dr. John Marshall from Washington, D.C., Dr. Jamie Chaft from New York City, and Dr. Scot Niglio from Bethesda will provide a brief overview of how immuno-oncology has revolutionized the management of gastrointestinal, thoracic, and genitourinary cancers. Then the panel answers questions on such important topics as selecting immuno-oncology versus targeted therapy for MSI-high cancers, what to do at progression on checkpoint inhibitors, neoadjuvant treatment with checkpoint inhibitors, and financial considerations when selecting therapy. For more information on Dr. Marshall, Dr. Chaft, and Dr. Niglio, along with a link to the complete program, including a downloadable slide set, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Hello, everybody. My name is Dr. John Marshall, live from Georgetown University. So let me kind of quickly run down the agenda. Each of us in turn is going to give you a little update in our areas of expertise. I'm going to talk about GI cancer. Scott's going to talk about GU cancers, and Jamie's going to talk about lung cancer. A lot of activity in each of these diseases. We're going to try to be efficient. But before and after, we thought we would kind of set the stage with some high-level discussion. So Jamie, let me give you first crack at this. Give me a big picture sense of how this has impacted your practice and some high level pearls that you would share.
So it's really fascinating to see the number of changes that have occurred across the thoracic malignancies. And I'll start first with what was chronologically the initial indications of second line therapy. And then we had a whole bunch of confusion about where does this biomarker PD-L1, which every company tests with a different assay, come in. I think this was eclipsed a little when we saw combinations of chemoimmunotherapy moving into the front line and further confusion about, do I actually need that PD-L1 stain? And then bring along small cell. This has been our unmet need in thoracic malignancies for a really long time. And for the first time, we've seen a change in the frontline standard of care with the incorporation of PD-L1 agents with chemotherapy. So certainly a new age for all of our malignancies, but one that's led to really long and complex discussions in the clinics with our lung cancer patients and is definitely going to improve outcomes.
Yeah, I would assume there's a pretty high level of patient awareness about this too. So lung cancer, direct to consumer marketing, all sorts of things that are influencing this. I would say particularly in your market too, that these are highly informed patients who have an idea walking in the door what they want to do. And it really puts us back on our heels a little bit when maybe we want to do something different.
Certainly. I mean, full page newspaper ads are common practice now. So we need to be aware of the data and ready with our biomarkers.
Yeah, I was reading the New Yorker last night in bed, and like the full page IO ad for lung cancer in the New Yorker. That's something. I'm used to seeing it in JCO, but not the New Yorker. Scott, what's your thoughts on all of this? I mean, there's so much activity in the urologic cancers in general, but they were sort of later to the table in some of this IO stuff. What's your reflection?
Well, I'd say better late than never, for sure. But I honestly, I don't think there's a better time to be practicing oncology. It's almost a complete renaissance of drugs just coming with activity. If you look at, I primarily do urothelial cancer and bladder cancer. But I mean, we had, basically 1-2 drugs before 2016. We had MVAC and then we had GemCis. And then that was in the 80s, and then we got gemcitabine early 2000s. Nothing happened, nothing developed, nothing could do it, hit it. And then like that, 2016, 2017, we have 5 new FDA-approved drugs in the second line metastatic setting. So it's certainly very exciting time to be practicing. And I think there's a lot to look at, especially from biomarkers to figure out who responds and how we get more people to respond.
Yeah. And I know in your practice, I mean, we all focus on clinical research, but in your practice, nowhere else like that, where, everybody's on trials. And so I'm assuming that this has just been great for research too, because you've got all of these new things to play with. And what we're seeing is, even unexpected combinations having benefit. And I know you guys have helped lead the way in a lot of that.
Yeah, absolutely. We went from a time where we didn't have many drugs to offer to now we have too many combinations to offer. And I think it's been very exciting. We've been able to get more options for more patients on clinical trial.
Well, thank you too. Now, I think increasingly important for our discussion today is that if you look at the key things that we look at, PD-L1, MSI-high, tumor mutational burden, we see that across all tumor types, there's variable overlap. And so in some cancers, we know that tumor mutational burden is important. We're going to hear about PD-L1 expression. In GI cancers, it's also MSI expression. So for each of these, they have their own important marker, but each of these is not yes, no. They're maybe yes, maybe no. And we need to increasingly get to markers that are yes, no. What molecular testing are you doing today for gastric cancer? Well, HER2, of course, using sort of breast cancer technology for that. We're using MSI. We're using PD-L1. Many of our indications require that in upper GI cancers. And of course, for all of the cancers we're talking about, we're looking for RNA fusions, specifically NTRK fusions. And again, we want to do germline testing in gastric cancer, CDH1s, but also for Lynch syndromes and the like. So if we drill down on the gastric cancer, we have approvals for squamous cell if your PD-L1 is greater than 10, and that's using CPS, and that's for Pembro. You've got second line with Nivo, and you've got third line with gastric or GE junction if their CPS is greater than 1. So you want to know PD-L1 status. You want to use the CPS score. We want to remember, too, that there are 6 different PD-L1 assays approved in the United States. So to kind of wrap this up, I just got a summary slide here of the various approvals of IO and gastric and colorectal cancer. I've reviewed each of these in turn. So we now have Pembro first line in MSI-high colon. We have any MSI-high cancer for Pembro across the board, but of course all GI cancers. You've got Nivo-Ipi for MSI-high colon. You've got Pembro for gastric GE junction, PD-L1 positive. But then when it's greater than 10, you've got squamous of the esophagus, Nivo without the biomarker enrichment for upper GI.
Thank you all for your overview. Now let's move on to some clinician questions. We have had a few questions for you, Dr. Marshall, on what to do for patients with CRC. There are multiple treatment options for CRC, depending on which biomarkers are present. For example, pembrolizumab for MSI-high disease, various BRAF inhibitor combinations for BRAF V600E mutations, and trastuzumab and pertuzumab for HER2-positive tumors, and even NTRK inhibitors for patients with NTRK alterations. For a patient with MSI-high CRC who also has other biomarkers present, do you recommend treatment with immunotherapy or with other targeted therapy first?
Honestly, that's a great question, and I think one that's unanswered at the moment. Many of us have a bias towards the immuno-oncology approach because of those very durable responses, because of the relative ease of administration and low toxicities for most patients. But that's an unknown, quite honestly. And I think you sort of get one of these reports back and it feels like a report of riches. You have so many choices from a therapeutic targeting perspective. So I think you have to use your clinical judgment in those spaces where more than one choice is available. But I do think there's clearly a trend in all of our talks to avoiding chemo or replacing chemo with immuno-oncology when the correct target is there. And then a second quickie for me was MSI and RAS mutations. Really doesn't have much of a role in picking. So if you're MSI high, regardless of your RAS status, immuno-oncology, immunotherapy would work. So RAS is really specific to just EGFR.
Dr. Niglio, you mentioned that in bladder cancer, there are now 5 immunotherapy agents approved in the second-line setting, and we know that biomarkers are used for pembrolizumab and atezolizumab in the first-line setting. Most recently, the phase 3 Javelin Bladder 100 trial showed significant overall survival improvement for patients receiving adjuvant avelumab compared with best supportive care. We have a few questions on which PD-L1 assay was used in the Javelin 100 study. Are the biomarker tests used for pembrolizumab and atezolizumab different? With so many different IHC tests available, which one do you use?
They used the SP263 antibody.
And I think, it's interesting if you send off your assays to companies to do this, there's, those that do immunohistochemistry, there's a really high level of knowledge that they use the correct antibody for the correct disease type. So there is that awareness, and frankly, to my knowledge, I have never seen anyone get the drug disapproved because they used the wrong antibody. I'm not sure our payers have picked up on the subtleties of that quite yet, but what do you two think about that?
So I was afraid to say that, but because based on FDA labels, but I think that's true. I don't think anyone's going to decline payment on a drug based on using a different test.
Yeah.
I mean, the reality is that the different antibodies also require different platforms, and those platforms are extremely expensive.
Yeah.
Right. And so just managing all of those different ones, particularly if you're choosing to do it in-house, becomes prohibitive.
Right.
I do know among the testing companies, they're sort of petitioning the regulatory agency to kind of agree on one platform for these assays and move those forward.
Dr. Chaft, in non-small cell lung cancer, frontline immunotherapy or immunotherapy combined with chemotherapy is commonly used. One question we see quite often is on the use of immunotherapy beyond progression. Is there a role for using a doublet like nivolumab and ipilimumab second line for patients who have progressed on single-agent immunotherapy in the first line?
There's not a whole bunch of data presented on this specific topic, not with this combination, but with the durva-tremi. I presented it. I don't think it's ever been published at AACR now, maybe 4 years ago. And the response rate was less than 10% in patients who had already progressed on a PD-1 or PD-L1 inhibitor. So it's really interesting that we see these tremendously durable disease control rates with frontline nivo-ipi, but it doesn't seem like adding the CTLA-4 to a PD-1 or PD-L1 really salvages anyone.
Great. This question is for all of you. Is there a role for neoadjuvant immunotherapy in your specialties?
So there's a really nice preclinical breast cancer mouse models as well as a lung cancer mouse model that I have seen presented but not published, really suggesting that there might be something unique to the immunobiology of using a checkpoint inhibitor with the tumor in situ versus trying to address micrometastatic disease in the adjuvant setting. So if I had my druthers, everyone would get a preoperative checkpoint inhibitor with chemo for lung cancer. If you have two drugs or two classes of agents that can improve outcomes in advanced disease, then the curative setting is the way to go. I do think there's a benefit of giving them preoperatively versus postoperatively based on our limited data sets, but we're still in the realm of figuring out who, what, and when to give these drugs.
Yeah. I mean, I guess it's easy to say you're going to do it in the locally advanced cases and then see if they changes their operability or local therapy options. But you're even arguing for, stage 2 disease and the like that you consider doing that, right?
Yeah, there are currently, there are 4 randomized studies doing this in the neoadjuvant setting, one of which I think is completely accrued and another nearing complete accrual. So we will know soon.
Yeah, at least in our space in the GI world, because we are very biomarker driven, we don't just have open approvals without biomarkers. It's been a little slower. And interestingly, our frontline data, say in gastric, was not nearly as positive as our second and third. And so gastric continues to be one of these mysteries for us. But if you look at colon, where the dramatic frontline data, single agent, I think you'll see more and more neoadjuvant. But in our world, adjuvant and neoadjuvant and metastatic are really very different because we have this EMT phenomenon. And so it's possible that the cells that we're targeting are actually in some ways different. I know there's a lot of neoadjuvant and urologic cancers. Scott, where's that going there? I think you already have it for bladder that you don't want resected, right? I mean, that's classic.
Yeah, so chemo. So at least the data in bladder, chemo has been king for a very long time. In the non-muscle invasive space, we have an approval. It's still maturing about the muscle invasive T2, locally advanced T3 area. There's a Pure One study that showed pretty good results. However, recently at ASCO, a study showed in the adjuvant setting in muscle invasive bladder cancer, and it was T2, T3, didn't meet its primary endpoint of disease-free survival. So it's still to be determined. There's another large phase 3 randomized trial looking at urothelial cancer, upper tract, and bladder, the ambassador trial of giving adjuvant pembro. So that's still accruing. When that comes out, we'll have some more data.
With the influx of immunotherapy approvals across many different tumor types, several clinicians are also asking about the cost of immunotherapy agents. In your clinical practice, how does the cost of treatment play into your and your patient's decision on which treatment to use?
So the only time that cost becomes apparent in the clinics is with our oral therapies. Yeah. So the cost of these other agents in our healthcare system, we're almost blind to it. And we shouldn't be, but these things are really done behind the scenes. With all of these PD-1, PD-L1 agents out there, one would imagine there could be some sort of competitive pricing, but we haven't seen it yet, at least at our institution.
I was going to say that, I think these are expensive medicines. There's no question, and there's been escalation, and our system is sort of backwards. We basically don't have the right to negotiate, but, like other countries do. And so we do have access that others don't. But when you start to also look at curves that we're looking at with drugs, with single agents that are, again, simple to administer, the drugs themselves are expensive, but people are not getting admitted to the hospital. They're not needing comorbidity kinds of medicines. And they're living longer. When you translate that into people continuing to be productive, paying their taxes, and all of those things to continue to contribute to society, it gets to be an interesting discussion.
Great. Thank you all for answering these questions and sharing your insights with us. Do you have any final key takeaways on immuno-oncology in each of your specialties? Dr. Niglio, would you like to start?
I'd say the key takeaways, starting real broad. Immunotherapy is here to stay and really disrupted how we treat patients that respond. Still a small percentage respond, but those who do respond really well. And we got to work on getting more responders. Biomarkers are changing every day, and we'll get a better idea who we can treat and how we can get them to respond better.
Dr. Chaft, any final key takeaways?
I'd say biomarkers for immunotherapy they're there, but they're not great. And we should use what we have, but we should keep working on finding better ones to prevent that early drop-off we see. These are not specifically predictive. They just enrich. And our patients deserve us to test these biomarkers as we have now, but we're looking forward to better ones.
Dr. Marshall?
I'll just add more to the same. Biomarkers early and often. And I do really think broad molecular profiling is part of our new standard. We do CAT scans of chest, abdomen, pelvis all the time when we know a lot of times they'll be negative. We do Chem 20s knowing a lot of times that most of that test will be negative. I actually think these broad panels are here to stay. We'll find things we weren't expecting and will drive our science. How in GI this is going to play in the adjuvant setting is less clear, but clearly for all patients with metastatic disease, early and often for biomarkers.
Thank you very much, Dr. Marshall, Dr. Chaft, and Dr. Niglio, and thanks to the listeners for joining us. As a reminder, to view the full program, application of existing and emerging biomarkers for immuno-oncology across tumor types, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. Thanks again.